Okay, good evening friends. Today we have the fourth lecture in this series of ECG, and we will be discussing today a topic which most of us usually know, but we don't know it in depth, that is electrical axis of the heart. We will try to cover this lecture concisely and will not go beyond the axis of the heart, right, in this lecture. We have already discussed in previous lectures that we have two types of leads. One is standard leads and the other is augmented unipolar leads. In standard leads 1, 2 and 3, they are equilateral triangle which have 60 degree between each of the leads. Similarly, we have augmented unipolar leads in which again you have 3 leads, AVR, AVL and AVF, and each of these leads have a 60 angle between them, right. So what we do is, we have a heart in our frontal plane and these are our frontal plane leads. So we will superimpose both the diagrams on one another, right. So what we do is, we draw lead 1 like this. This is lead 1, negative lead is here, negative electrode is here, positive electrode is here. This is 1. Then I take lead 2 and put it over like this. So it makes a 60 angle, right, like this. Negative here, positive here. This is lead 2. Then I take the lead 3 and put over like this. So it goes like this. Lead 3, positive and negative. So each lead is making 60 angle between one another. So now I'll take AVR and will put here like this. AVR positive is at my right shoulder, so this is AVR which is positive. I take AVL and I put on my this axis, so AVL positive, negative, and AVF I take it and I put here AVF. So now we have a combined hexagonal system of finding the axis of the heart. Each lead is making 30 angle between one another. Now just you have to imagine that my heart is here like this. So it's a virtually we have a heart which is like this. So it is inclined towards the lead 2. We know this by heart. Now something which we need to imagine. Say for example, you have lead AVF, this lead AVF, single lead, negative is here, positive is here, this is lead AVF. I plot QRS according to the vector. Suppose the vector is moving like this towards the direction of the positive electrode, so the QRS would be positive, right? No doubts. Suppose the vector is moving like this, opposite from positive eye of this lead, the QRS will be like this. This we have already discussed. Now just see, suppose the movement of vector is like this. That means my heart is rotating with respect to lead AVF. Now there is a component which is in rightwards direction and there is a relative component which is in downwards direction, right. So the positivity of QRS will be slightly less as compared to when it was going directly in the direction of lead AVF. Suppose it goes like this. So again it will be negative, but the direction of QRS will be less as compared to when it was going directly in the direction of negative electrode. Suppose heart is rotated in a way that the electrical force is directed like this or this, which is at 90 degree, which is perpendicular. So either the deflection is 0, they cancel out, or it is otherwise it is known as equiphasic deflection. That means suppose we track the PQRS, so something will be like this, equiphasic. Negative and positive are equal. So we have a complex. That means suppose this is lead AVF, and QRS is like this. What does it mean? That the mean QRS vector is perpendicular to AVF. So whenever we find an equiphasic or very less deflection of PQRS or T, so it means that the electrical current of the heart for that wave, that means that P wave, that QRS or that T is traveling perpendicular to the lead. So there is a relation. The relation is, if you have equiphasic deflection in lead 1, you have an equiphasic deflection in lead 1, that means the current is traveling perpendicular to lead 1. That means current is traveling exactly in the direction of lead AVF. So we have a pair, lead 1 and lead AVF. So lead 1 and lead AVF are perpendicular to each other. Similarly, if we have an equiphasic or a null deflection in lead 2, that means I will have maximum deflection in AVL because the current is directly perpendicular. So if I have an equiphasic deflection of QRS in lead 2 or I have a null deflection of QRS in lead 2, it means I have a very robust deflection of QRS in lead AVL. You're getting it? Suppose I have 0 deflection of QRS in lead 3. Suppose I have a 0 deflection of QRS in lead 3. That means the current denoting QRS of my heart is traveling perpendicular to lead 3. What is perpendicular to lead 3? AVR. So my current is traveling parallel to AVR. You're getting the point? Now we'll see an example. This is a hypothetical ECG I have drawn. We'll just try to find where is my QRS axis. We'll just try to find in this diagram where is my QRS axis. So I'll apply the same principle. I see that in AVL I have an equiphasic deflection, something which is negative, something which is positive, and they are more or less equal. So out of all my frontal plane leads, out of all my 6 frontal plane leads, I will try to find out which lead has the most equiphasic deflection. That is the first principle in determining the axis of my heart. Getting the point? So whenever you encounter an ECG, in first 1, 2, 3 AVR, AVL, AVF, try to find QRS which is the most equiphasic. So I see that AVL has the most equiphasic deflection. That means the electrical current which is producing QRS is traveling perpendicular to AVL. So what is perpendicular to AVL? Lead 2, and you see that lead 2 has the best QRS deflection. Lead 2, the direction is, this is 0, this is 30 plus, this is plus 60, so that mean QRS vector is directed towards plus 60. This is plus 90, plus 120, plus 150, this is 180. It can be minus also, it can be plus also, depending upon how you see it. Here it is negative, negative 30, negative 60, negative 90, negative 120, negative 150. This is clear, na? We have 30 degree differences. So the moment I have a QRS which is equivocal, I try to find its pair in a perpendicular lead. This is the first way of finding the ECG axis, right? There is a possibility that you don't find a QRS complex which is equiphasic. There is a possibility that here it was like this, slightly more positive deflection as compared to the negative deflection. That's a real possibility. So you again try to find which complex has more or less equiphasic deflection. So again, this is the one which has slightly equiphasic deflection. Now the QRS axis will be where? Question is this. See, this is my AVL, this is my lead 2. Right? Positive, negative. So I have a QRS which is slightly positive. So there must be some positivity here. And when I see my lead 2, it's very nicely positive. So you have a good positivity here. So what will happen is you find a resultant vector like this. You're getting the point. So the moment it is equiphasic, you have the mean QRS vector which is directed exactly in the perpendicular direction to the perpendicular lead as per this. The moment you don't have an equiphasic deflection, it varies accordingly. Either it will go towards positive side if you have a positive deflection, or it will go towards negative side if you have negative deflection. So the third way of finding a QRS axis is that I see, suppose, lead 1 and lead AVF. In lead 1 I have a positive component of 10, negative component of 2, so the net component is 8. In lead AVF I have a positive component, I count 111 millimeter, right? I have a positive component of 7, negative component of 2, so it is 5. So what I will do is, I will draw my 1 AVF in my mind. You have to practice it in your mind when you see ECG in your exam. You take lead 1 and AVF, calculate and do it in your mind. 1 AVF. In lead 1 we have 8. 1, 2, 3, 4, 5, 6, 7, 8. 8. In lead AVF we have 5. 1, 2, 3, 4, 5. Resultant vector. This. Got it? So that's the way of calculating exactly where my QRS is pointing. Right? Either you find a equivocal deflection, more or less equivocal deflection, or you calculate the total positive components in your perpendicular leads, try to plot it in your mind. You can plot it on your graph, you can plot it on your paper, but you can exactly calculate where your electrical axis of heart is. The best way is find equivocal deflection. That will give you the best approximate idea where your electrical axis of heart is. You got the point? Right? Now, in my diagram, if I draw 360-degree diagram, so this axis, this part, this 90 degree is what you call as normal area, where my normal axis of heart is, that is 0 to 90. From 0 to plus 90 degree, my QRS axis will vary. Ideally, it is at 60. 40 to 60 is the ideal axis of QRS. This is your mild LAD, mild left axis deviation, 0 to minus 30. This is your severe LAD, minus 30 to minus 90. This is your northwest axis or extreme RAD, minus 90 to minus 180. Where do you find extreme right axis deviation? We talked in a previous lecture of arrhythmias, right? When we were talking of difference between VTach and SVT with aberrancy. So there was a point that the axis will point towards extreme right axis. This is your extreme right. This is your right axis. Plus 90 to plus 180. So if you look at from here, it will be plus 180. If you look at from here, it will be minus 180. Right? See, whenever we talk about axis of heart, we are generally talking about QRS, generally. But the same principle applies for P wave axis also. We can find axis of P wave. This is for QRS. What will happen for P wave? Now see, in this diagram, I'll try to find which lead is showing me the best equiphasic deflection. Lead AVF is showing the best equiphasic deflection, right? Rest all have positive or negative. So AVF has equiphasic. So which is perpendicular lead for AVF? 1. The perpendicular lead for AVF is 1, and you can see the P wave is most positive in all the leads if you try to compare it, right? So where is my axis? My axis is in lead 1. So the axis is 0 degree. P wave axis is 0 degree. You're getting the point. We have a P wave which is equivocal in AVF. So that means my P wave is in the direction of lead 1. Lead 1 is pointing towards 0 degree. So if you have an ECG where you find a P wave which is equiphasic in AVF, that means the axis of P wave is in the direction of lead 1, and the direction of lead 1 is pointing towards 0 degree. So in the same ECG you have two axes now. One is QRS which is directed towards 60 degree, and one is P wave axis which is directed towards 0 degree. This can change. So this question can arise. Someone may ask you, can you find a P wave axis? So you can. The same principle you can apply, which is for QRS axis to your P wave axis, right? You generally don't calculate T wave axis. You generally have a relationship between QRST. It is taken in toto. If someone asks you, can you find with the same principle T wave axis? You cannot. You can say that I have a QRST angle which is 60 degree. I'll not go into detail. If you want to understand about how QRST angle is determined, it's of not practical significance, but how QRST angle is determined, you can go into Shamroth and read about it. But remember, the angle between QRS and T is 60 degree. Generally it is 45 to be very precise. The angle of QRST is 45, right? You cannot determine T wave axis independently. So we'll cover two more aspects. What are the major contributors to left axis deviation of heart, and what are the major contributors of right axis deviation of heart, and how my ST segment can change its axis, right? So before that, you remember that QRS axis, QRS electrical axis points away from area of injury or any mischievous area, any troublesome area. QRS vector will change its direction from that area. So suppose my right ventricle gets infarcted, so the whole QRS segment will shift towards left. if my left ventricle is ischemic or infarcted, the whole QRS segment will shift towards right. Right? So that is the significance of shifting. In ST, opposite applies. It prefers shifting to site of injury. To site of injury. Suppose I develop inferior wall MI. I have inferior wall MI. So by convention, we always say that in lead 2-3 AVF, you have ST elevation. This is a convention, we understand, but why? The principle is this. Why? The principle is this, that my ST segment will deviate towards the site of injury. AVF, lead 2, lead 3, positive, positive, positive. I have a problem here. So shift of ST electrical axis, is towards the injury site. So if anything is shifting towards the side of the electrodes, what will happen? You will have positive deflection. So ST elevation is technically the deflection of ST as positivity. You're getting the point? ST is a isoelectric line. ST is a isoelectric line. So ST elevation is that my ST segment is elevated just like a P wave elevation in towards lead 2-3 AVF. So in 2-3 AVF, I have ST elevation. What will happen in 1 AVL? In 1 and AVL, something is going away from them. It's going away. What will happen? I have ST segment depression. You know, by convention we understand that whenever we have inferior wall MI, my ST elevates. But why it elevates? The reason is this. Getting the point? T wave, it follows the same as QRS, we discussed it. It follows the same principle. So the moment you have a site of injury or ischemia, the T wave deflection will be opposite from the site of injury. Again, we take the example of inferior wall MI. So my current will start traveling away from the site of injury. This is the site of injury, inferior wall. Current is traveling away. So what will happen? T wave inversion occurs. So this is the principle. You have T wave inversion, right? At the site of injury or ischemia. Why? Because T wave electrical axis travels away from the site of injury. QRS travels away from the site of injury. ST travels towards the site of injury. Is it clear? Now we come to left axis deviation. By left axis deviation, I mean anything from 0 to minus 90 degree. 0 to minus 30 is mild left axis deviation, and minus 30 to minus 90 is moderate to severe left axis deviation. So what are the causes? First is inferior wall MI. Now just imagine my inferior part is, injured. So where should the QRS moves? It moves like this. It moves superiorly and leftwards. So electrical axis goes left, right? So the principle applies very smoothly here. Then you have left anterior hemi block. You have two fascicles. In left bundle, you have two fascicles. One is anterior superior, that is left anterior fascicle, and other is posterior inferior. Anterior superior, posterior inferior. So you have to imagine like this. This is the antero-superior part or left anterior fascicle. It gets blocked. So activation is occurring down like this. So again, the shift is leftwards. right? If it had been left posterior hemi block, the shift would have been rightwards, right? The activation of the LV myocardium is taking place through LP, left posterior fascicle. So that is why electrical axis is shifted towards left side, right? If you have, suppose, just imagine you have ventricular tachyarrhythmia which is taking place from left ventricle. A VTAC starting from here, left side, left ventricle. So the QRS will shift away from the problematic area, so it shifts again towards your left side. So right, inferior wall MI, left anterior hemi block, VTAC. Suppose I am pacing my ventricles. I am pacing my ventricles by artificial pacemaker. The leads are in either right ventricle apex or left ventricle apex. Pacing right or left ventricle apex. So again the same principle of VTAC. What will happen? The moment you pace, the current will change its direction towards your left side. Getting the point? Lastly, you have Wolff-Parkinson's White syndrome, wherein you have some tracts known as right posterior or right posterolateral tracts. They are aberrant tracts. So if the activation is taking place either by right posterior or right posterolateral tracts of WPW, you have left axis deviation. So at least try to remember three causes of left axis deviation. One is inferior wall MI, one is left LHB, third is ventricular tachyarrhythmia arising from left ventricle. Sometimes you may be asked that whether pregnancy or morbid obesity contribute to LAD. Mind says yes, you have lots of obesity, heart should shift. Pregnancy, again heart should shift, but the studies don't prove it. So for you as students of medicine, pregnancy and morbid obesity do not cause left axis deviation. Now we come to right axis deviation. So right axis deviation, anything which is from plus 90 to plus 180 degree. Right. So first cause should be LPHB, opposite of LAHB, left posterior hemi block. The moment you have left posterior hemi block, entire current will travel to left anterior fascicle, so the current is traveling superiorly and towards your right side, right? So LPHB. Second, you have anything which causes right ventricular dominance. By right ventricular dominance means that entire pathology is, or I should not say pathology, the problem is such wherein the right ventricular electrical or mechanical activity is predominant. Say for example, you have acute pulmonary embolism, acute PE. In acute PE, you have sort of acute cor pulmonale. So your right ventricle is strained. So electrical activity is directed towards that part, right? Acute pulmonary embolism, or you have acute cor pulmonale. Here you have right axis deviation. In inferior wall MI, we are having left axis deviation. So what technically could be opposite to my inferior wall MI? It could be anterolateral MI. If I have an anterolateral MI, the axis would shift from anterolateral side towards inferior and right side. It goes like this. So once I have anterolateral MI, my axis shifts towards right side. So remember these three only: left posterior hemi block, anything which causes right ventricular dominance, and anterolateral MI. In LAHB, one thing which we missed is that LVH, whenever you have hypertrophy, you can have fibrosis of LAHP, left anterior fascicle. So LVH can have left axis deviation only if left anterior fascicle is fibrosed, but there will be no LAD if there is simple hypertrophy without fibrosis. No fibrosis. So if you have a case wherein you have LVH and you find that patient has LAD also, that means there is a fibrosis which is causing conduction impairment in your left anterior fascicle, right? If you don't find left axis deviation with your LVH, that means there is no fibrosis in your conduction system, right? So in brief, we'll just recapitulate. We'll stop here, that how to find our electrical axis. We can find our electrical axis in three ways. We find an equiphasic component and we find a lead which is perpendicular to that equiphasic component, and my axis in 100% in the direction of that perpendicular lead. If I don't have a equiphasic component, then I find a lead which is showing somewhat equiphasicness and I plot a graph. Thirdly, I can directly go to my independent leads, 1 AVF, 2 AVL or 3 AVR. I find a sum total of positive and negative, and I plot the graph and find my axis. I know that where my axis is looking, is it northwest axis, is it left axis or right axis, right? I know the cause of left axis deviation now and right axis deviation now. Remember that ST segment elevation is a reflection of just a P wave or QRS movement in the direction of injury, whereas QRS and P wave moves away from the direction of injury. Same with T wave also, right? So we'll stop our lecture here. In next lecture, we'll try to finish off our P wave abnormality, what is normal P wave and what are the variants of P wave. Thank you so much.